Welcome to Conspiracies Against Wellness with your host, Janelle Elgaway.
And now, the host of Conspiracies Against Wellness, Janelle Elgaway.
Good evening, and welcome to Conspiracies Against Wellness on CAW 360 Network. I'm your host, Janelle Elgaway. There are two ways to listen into tonight's show: through our website, www.cawnation.com, or YouTube channel, Conspiracies Against Wellness livestream. If you have a question for our guest this evening, you could call in at 415-403-2715. And now I'd like to introduce Dr. Margaret Aranda, our guest this evening. How are you doing, Dr. Aranda?
Hi, I'm doing fine. Thank you so much. How are you?
I'm doing well, thank you. Just a quick question. YouTube land, is there an echo or is everything good? I just want to make sure quickly. I think everything's good. Okay, we're going to just go from here. So, we're so happy to have you. Can you tell me a little bit about yourself? And I know you're a CPP as well. Can you share a little bit about that, please?
Sure. I think I had a pretty rough road about 13 years ago. Actually, it was more about 15 years ago. My daughter and I were involved in a car accident where somebody T-boned us going about 90 miles an hour. They spun us in a circle, and really, it was a Tuesday afternoon at 2 o'clock in the bright sunshine in front of Pepperdine at Malibu, and my whole world turned upside down. I didn't know it at the time. I didn't know it for months, actually. She ended up totaling her car and the car behind me, and she broke the rear axle of my Ford Expedition. So it was a pretty hard hit. And then because she swirled us around in a circle, it basically centrifuged my brain around in a circle too. And I ended up with a traumatic brain injury. Eventually, I couldn't walk or talk. I had to go into Northridge Hospital brain rehab program, and I had to go through 6 courses of speech therapy just to say the word "the." Because I had to look at her mouth and see where her tongue went and everything. I mean, it was really hard. But with that being said, I then assumed the clinic of Dr. Forrest Tennant after reading that one of his patients, Jen, committed suicide when he was out of town to testify for another doctor. And that really upset me because the climate in our country was very harsh and a lot of people were already starting to commit suicide. And I thought that that was something that really shouldn't happen. So I basically just did a Google search on his name, and instead of the top 10 hits showing up, there was a black screen with his name and phone number in white. And I thought to myself, God, I must be trying to talk to me. I guess I'm supposed to call. So I did. And they tried to scare me away by showing me big, huge charts, like 4 inches thick, like about 3 or 4 of them on some of the patients. But honestly, I had been out of medicine for 13 years. I was bedridden for a full 12 years. I ended up with the vertebral artery dissection in the back of the neck. So it goes to the back of the brain. So I was nauseated and vomiting constantly. I also had dysautonomia. I could not stand up without fainting, and I passed out on the tilt table test. So I was very, very ill, and I just thank God that I'm here today and that I got better.
Now, how long have you been a doctor and practicing?
I graduated med school in 1990. And now I've been running the clinic. I've had the clinic now for about in July here.
I'm so sorry, that didn't come through. Could you please say that again?
Oh, sure. I started the clinic. I volunteered for May and June, and then I moved the clinic to Malibu in July. So I officially took over the practice, or assumed the practice, on July 1st, and have had it ever since then. So it's been about 8 or 9 months.
Okay. Now, what kind of what do you provide for your patients, and what type of patients do you handle?
So that's a great question. I handle basically some of the sickest patients in the country. About half of our clinic comes from out of state because there's nobody else that really knows how to care for the main diagnosis that I take care of is something called adhesive arachnoiditis. It's a spinal cord injury. In short, it's a very painful syndrome, 24/7 pain that turns into something that's extremely all-encompassing for the patient. It affects their sleep, their marriage, their diet, everything. And so most patients have that. It's also a very undiagnosed problem. So, and it's estimated that many people who have failed back syndrome from multiple surgeries or epidural steroid injections may actually have arachnoiditis also. And because it's thought to be so rare, it's not diagnosed very often. Most medical students and most doctors have never seen one case of it. So it's hard for them to know what to look for.
So I imagine when you see your patients, they probably have, they're probably at the end of their rope, and they've probably tried everything possible and have no hope. Is that correct?
That's absolutely correct. They come to us very sick. They have very unusual presentations because there's so much stress and so much pain. So actually, one of the things that they do commonly is I'll find sweating under the eye, on the bottom eyelid, which is a very interesting finding. And they also sweat, on their forehead and everywhere else too. But their stress response is constantly activated, and so much so that it's not unusual to see these patients suffer from something called Addison's disease, where the adrenal gland that supplies epinephrine and our stress hormones that keep us activated during stressful times, it basically just gets worn out and they don't have any cortisol left. So they're dying. They're slowly dying.
Now, these shots that they are getting arachnoiditis from, what type of shots are those?
That's a good question too. Mostly I'm seeing epidural steroid injections, either for pain management or for labor and delivery. We just had a phone call today from a woman who had a labor epidural placed, and after she had the baby, her whole life turned upside down. It sounds like she has arachnoiditis.
Now, when you get these patients, obviously you can't promise them that, everything's going to be okay, but what is the turnaround rate? What do you do? What happens when they first come in, and how do you handle them?
When I assumed the clinic, almost everybody had the same diagnosis. Everybody was on some of the same medications, such as opioids as a classification. Other patients were on sex hormone replacement therapy. There's everything from diuretics and hormones, steroid hormones, as well as non-steroidal anti-inflammatories. There are about 15 different classifications of drugs that I use. So in order to know who needs what and what they're missing, I draw probably about 60 labs on everybody. When they get here, I look at inflammatory markers, the entire endocrine system. Of course, the regular things like the blood count. It's not unusual to find patients are anemic also when they come in. And they have really soft, brittle, soft bones. They have osteopenia as well. And their muscle mass is tiny. They have lost their muscle mass as well.
Okay, so they have atrophy. Now, you do more than just a regular blood workup. What exactly do you do, and what are you looking for?
I do very comprehensive labs that an endocrinologist would look. So I'm looking at everything from the brain, how the hypothalamus and the pituitary gland talk to the end organs for the endocrine system. That includes the thyroid gland, as well as the sex organs, the ovaries, and then I also check for viruses. We find many of our patients are positive for Epstein-Barr virus, or EBV. That's associated with mononucleosis and also chronic fatigue syndrome, or myalgic encephalitis. So they have like a brain injury. A lot of them are very slow thinkers initially. You can tell they're struggling for words sometimes, or they're speaking very slowly, or they're not able to comprehend a whole lot of information in a short period of time, for example. And I also check the normal things like the blood count, the liver, the heart, the kidneys. And I do a lot of inflammatory markers looking for signs of inflammation so that we can target some therapy to that as well. I also do vitamins. I do vitamin B. Vitamin D is a big one because these, patients who are chronically ill, especially if they're bedridden, they're not putting a lot of gravity on their bones. They're like living in outer space. So their bones become very weak. So I check for that too. I send them for a DEXA scan. Many patients with arachnoiditis also have difficulty initiating a stream of urine or emptying it out all the way. They can't tell when it's full or when it's empty. So I send patients for a bladder scan as well. And other things I look for men especially, I check the prostate specific antigen, the PSA, because when I put patients on hormones, especially testosterone for men, we want to make sure that the prostate gland stays healthy and doesn't become inflamed.
So the majority of your patients, they are arachnoiditis, and what else? What other types of issues do you treat?
The main diagnosis I think that everybody has in the clinic is something called central pain. It's pain 24/7 that's intractable. You can diminish it a little bit, but the problems that these patients have cannot be cured by surgery. They cannot be cured by stretching or yoga or doing anything at all whatsoever. So most patients have central pain, whether it's from arachnoiditis or fibromyalgia, Lyme disease. I have extremity injuries, amputations, other types of spinal cord injury, and some people also have a little bit of a traumatic brain injury as well.
So how do you deal with patients like this?
It's a very stepwise program. Right now, if you're a brand new patient coming in, there are 4 phases or 4 protocols of therapy. So on day 1, you'll get phase 1 protocol. And then the second month, you'll get more medications, same with the 3rd month and the 4th month. And so some medications, such as metformin, for example, that's something that diabetics normally take to lower blood sugar. Coincidentally, somebody did a study and found that if that diabetics on metformin live longer than normal healthy patients not on metformin. So it's used as an anti-aging, longevity kind of medication also. But our patients are very sensitive to the drugs in general. A small amount of drug will generally go a long way. So for some medications, they'll start on 1 of those tablets a day, or even Monday, Wednesday, Friday only for the first month. The second month, I try to double it. The 3rd month, triple it. The 4th month, quadruple it. So it may take, I'd say, 4 months for somebody to be on the full regimen of all the medications I would like them to be on.
Nurse from YouTube asked, would you have urine incontinence with arachnoiditis? I don't feel I need to urinate, but it just flows out. A lot of cough, sneeze, etc.
Exactly. A neurogenic bladder basically doesn't talk to your brain, and your brain doesn't talk very well to your bladder either, because the impacted nerves in the sacral spine end up causing that syndrome. And yes, we have patients can either lose urine or they can actually even lose stool too. Many patients have rectal pain, pain in the testicles, the penis, the clitoris, the groin area, the buttocks, the upper thighs, and a sciatic distribution. And that kind of burning is like CRPS. It's a chronic regional pain syndrome or reflex sympathetic dystrophy. It's a 24/7 burning, stabbing knives constantly 24/7. It wears on people very much. And central pain changes the brain. So that small amounts of pain that normally don't hurt actually have an exaggerated effect, like allodynia. Some patients, you can't even touch them on the certain parts of their skin. They can't get that skin under the water in a shower. They can't let the wind blow on it. It's sort of symptoms that you would think that's impossible, but they can't do it. It's their skin receptors change, the brain changes, and so central pain is something that we're always struggling with. But to answer the question more thoroughly on the bladder issue, yes, I send patients to a urologist I also have them do a bladder scan, an ultrasound of the bladder. It's called a post-void ultrasound. So they go in, the first ultrasound is a full bladder. So patients should be instructed to drink a lot of water, and they should have like 200, 300 cc's in there. And then they are instructed to go ahead and urinate. And they're not supposed to push out any urine with their brain. Like they're supposed to just stop when the bladder tells them to stop. And sometimes what we actually want to see is how much urine is left over there. And if the volume is over a certain amount, then yes, they have a neurogenic bladder. There's medications for spasm. There's medications to make the muscles tighter so you don't lose the urine. And a urologist certainly is needed at that point to pick the best medications for each patient.
Okay, so I come into your office, say, and I don't know what, and everybody's told me it's been in my head. I'm scared. What do you do?
Well, the very first thing I like to do is give some reassurance that this is a refresh page and where everything is new, and let's just take things a little bit slowly at a time. I make sure that patients know my story if they don't already, and I tell them what happened to me, and then they look at me sort of with different eyes, like, you understand what it's like to be bedridden, to lose your family, to lose your job, to have your world kind of crash around you. You're not dead, but in a way you die to a lot of the things that gave you life before. So I first try to be very encouraging. And then I think the best thing that I could possibly do in the first few visits is elicit the best medical history that I can. If somebody was in a car accident, I want to know how fast were they going? How fast was the other car going? Were they wearing a seatbelt? What happened to the car? I mean, I ask a lot of details about what started this whole thing in the first place. And many times that's very helpful to me in estimating the kind of damage that I think they may have and sending them for some studies. And we found some very interesting things. One lady, she complained that after she ate, she felt like the food went up to her throat. It went up to here the more she ate. Like she couldn't eat very much and she felt like throwing up every time she ate. Well, I had gastroparesis because that gets affected if you're diabetic. It gets affected if you have arytenoiditis as well. And I sent her for an upper GI, so they put a scope in and checked out to make sure she didn't have, anything going on in there that was an obstruction. Well, they found a Bosar. It's like a cluster of hair and particles that were undigested that had probably been there for years. So I recommended that she find some papaya seeds. They have enzymes in them that break down food in the stomach. And so that could help break it up.
How important is diet?
Diet is probably the most important thing that people can do every day to make good choices that will make their pain a little bit better. There are anti-inflammatory foods, there are elimination diets, there are antihistamine diets, and the low glycemic diet is something that people should be on for life. But certainly we have a protocol for that. But everybody gets a diet protocol and an insomnia protocol as well. Because the first two things I want to do with people, number one is to get them to sleep overnight, because even a normal healthy patient who doesn't sleep at night will feel really badly after 2 days, let alone 2 months or 2 years. So our patients need to sleep. And then the diet, we have a protocol for that too. So we make some very specific recommendations.
Is the diet individualized or do you have kind of like a go-to?
It's not individualized. The first thing people should do is the Whole30 diet. It's an elimination diet. It eliminates dairy and other foods that are allergic that most people can be allergic to. And it's a very well-entrenched program. Millions of people have gone on it. There are books and videos, and they have a community, a forum. They're big on social media. You can hire one of their coaches, a Whole30 coach. So it's a very, very good program to reprogram yourself on making good choices, whether you're traveling or at a wedding or a party, still making good choices. So your commitment is for 30 days when you start that. And there's very specific instructions before you start it and during. There's a lot of support during the time as well. After that, the diet that I recommend people to do next is called it's a histamine challenge. A lot of patients with dysautonomia also have a mast cell activation syndrome. So you don't want to trigger mast cells to produce histamine and allergic reactions after you ate something. either that you're allergic to or are foods that actually contain histamine in them. So I do a challenge with fermented food on day 31, say. You start introducing back foods one at a time and do something like pickles or kimchi or a 3-bean salad. And then if you become have a lot of diarrhea or you're very, very bloated, you need to maybe stay away from fermented food and go on an antihistamine diet. And that's a very difficult diet to be on. It's very select. And then if you're okay with fermented food and you can eat yogurt and things like that as well, then you move on and go to the low glycemic diet. And that's another diet that's extremely well entrenched and has anti-inflammatory sub-diets. There's an anti-inflammatory sub-diet on the Whole30 as well. So the diet's an anti-inflammatory one. We don't want to see chronic metabolic syndrome, pre-diabetes, or diabetes, because that will just lead to more things like heart attacks and strokes.
A lot of people on YouTube are asking, where can they find these diets? I mean, are they online somewhere, or is it something that you make up?
Perfect. No, I didn't make any of them up. I can't take credit for them. The Whole30 diet is on whole30.com, WHOLE30.com. That's a really easy one. There are books, tons of books written on the subject, and a lot of YouTube videos they have also. So that's a pretty easy one to find. And the community is very active. So it's a really nice community. And then the antihistamine diet, there are books on that too. The low glycemic diet is all over the place. You can go to Pinterest and find infograms about the foods that you can eat. It's basically a lot of vegetables, low not only on sugar, but on bread, pasta, rice, even beans, things that have a high glycemic index, trigger your pancreas to secrete insulin. And the more your pancreas secretes insulin after you eat, the more likely you are to become insulin resistant and then develop prediabetes and diabetes. So it's good to stay away from those foods.
So, all right, so I'm doing the diet and I'm 60 to 90 days in. What else am I doing? What else are you going to be helping out with, especially with the rare, painful diseases?
Right. Well, since the second component after diet is sleep, I try to put everybody on get everybody to reestablish their day and night cycles. And the day and night cycles are regulated by melatonin in the brain. It gets released when the sun starts to go down and it starts to get dark. So what I do, I like to keep trying different melatonin formulations, whether they're 3 milligrams, 5 milligrams, 10 milligrams, maximum dose is 25 milligrams. And then also, there is also some melatonin ERs that are extended release, so they not only put you to sleep, but they help keep you asleep. And I prescribe those at 10 milligram doses at a time. And every instruction for me, when I prescribe melatonin, I do it together with a separate prescription of magnesium. Most people are deficient in magnesium. It's a very good drug for your heart and your muscles, but it also is a muscle relaxant. So it can help you sleep. And for women that get migraines especially, or postmenopausal women who get headaches, it can help a lot with that. So that can help with the pain also, as well as just sleeping.
I know you do a lot with hormones. How important is a woman's hormones concerning if they have also a disease and health issues?
Right. Well, if patients have been chronically sick for a long time, it's a survival mechanism that I think God pre-programmed us with. If you're trying to fight for your life, having sex just isn't a great priority. So most women and men alike with a low or zero testosterone level haven't had an interest in sex and have no sex drive. They really don't even miss it. But when we start replacing that, and I also like to replace progesterone and estrogen in women, then not only does it help the bones absorb more calcium, it helps your energy level all day. It helps you do more during the day, so you're a little bit more tired at night so you can sleep better. I believe it has a great beneficial effect on lifting brain fog that so many suffer from, as well as increasing muscle mass, because most people are not eating enough protein. Everybody who has a chronic illness, unless you have a kidney problem or a contraindication, every meal should have about 20 grams of protein in it, because it's really important. Maintaining your muscle mass is something that we focus on in aging, but it's also very important with chronic illness because the body isn't being used. And so the muscle mass gets lost, and it's not just an atrophy. Many times it's sarcopenia. It's a lack of the sarcomeal muscles in fibers in the muscle. It's like aging. So we try to build that back up. But we not only use the sex hormones, I also work with human growth hormone, or HGH, as well as human chorionic gonadotropin, or HCG. I work with nandrolone, oxytocin. There are a lot of drugs that can help with neurogenesis, or generating new nerves. I also give vitamin D together with vitamin K. So it's a vitamin D3 with K2, which the vitamin K increases the absorption of the vitamin D. And everybody gets to inject 1,000 units of vitamin B once a week. So that hopefully as they're growing new nerves, they have a myelin sheath that can function around them. And so we can keep ahead of the long-term plan, which is to grow nerves kind of at the speed of a fingernail growth, so that eventually, patients can get better. And I'm really, really happy to say that we've got some great miracles in our clinic. We have had some people really respond really well to some aggressive therapy. I have a grandma who went on a roller coaster with her grandchildren. I have young people going back to school and getting jobs again. They're pretty much working me out of a job. They're getting better. So we're always hoping that when people come to us really sick, eventually we'll be able to make you well enough to just go back and be in the family and do the things that you want to do. And that's actually our motto, keeping you in the family, because that's what we're working so hard for. Get you back.
I know. The majority of my audience is chronic pain patients, including myself. And a lot of us we lose that hope, and because so many doctors have either turned us away, said, you know what, your case is so bad, we can't do anything for you. So this whole combination that you're talking about, first of all, I want to know, why aren't more doctors doing this?
I don't know why most doctors aren't doing this. I can tell you, though, it's not easy. It's hard. And if I draw 60 or 80 labs on one patient, I'm responsible for all the results, and I have to do something about it, which is why a lot of the primary care doctors just let me go ahead and order it, or they'll take my orders and they'll order everything for me because they actually want to follow everything. They want to see how I do things. So as we're going along, I'm definitely teaching other doctors what to study, what to check for. And I think there are a lot of doctors that would like to know these things because they need the encouragement too. There's nothing better than seeing a really sick patient get better and do things and have I had another patient told me she put on a birthday party for her 9-year-old son. She hadn't given him a birthday party in years. Her mother was there, her sister was there, and they were actually crying at how good she looked and how much she was able to do. And that any doctor would love to have their patient do that.
Yeah, that's amazing. Are you going to do you teach other doctors?
Well, I have some lectures that I'm coming up with. I have another book that I'm writing. So yes, I am there to teach other doctors because this is a disease that they don't get to see. I would love to be, affiliated with a medical school eventually and have residents and fellows who can actually learn from very sick patients. There's no question that the patients in our clinic are not faking it. There's nothing that's all in their head. They're very sick, and they're really blessed to be getting a little bit better and gaining some quality of life back. So I think we doctors still have a lot to learn about spinal cord injury and arachnoiditis.
Yeah. Does insurance cover this? Because a lot of us are on disability, Medicare, or Medicaid. So how does that work?
In my practice, because I took the practice over, I assumed the clinic sort of overnight. I'm not credentialed with any insurance companies. That takes months and it costs money to credential with each separate one, all the carriers. So I don't take medical insurance. However, patients are welcome to get a super bill for my services. And then usually since I'm one of the only doctors in the entire country that can manage this diagnosis, usually the insurance companies will go ahead and reimburse the patients for it.
How do you diagnose arachnoiditis? Because I know a lot of people, it goes undiagnosed for a very long time often, right?
That's true. That's true. The very first thing that you need to do is get the history and find out what happened that brought the patient to you. In eliciting that history, you need to look for another syndrome called Ehlers-Danlos syndrome. Ehlers-Danlos syndrome is a condition that makes patients prone to get arachnoiditis in the first place. And patients, I believe, with EDS or Ehlers-Danlos syndrome should not be getting epidural steroid injections. They should not be getting instrumentation of their spine because they rip and they end up with slow cerebral spinal fluid leaks for decades after instrumentation. But to answer your question more directly to what do I look for, besides the history of back injury, as well as a history of EDS or other comorbidities, I really pay attention to the physical exam. And I do a physical exam differently than most because the spinal cords are so super sensitive and get activated. And I don't want patients to be crying for 3 days because I took a hammer to their knees, for example. So what I do is I look at the back first. Classically, patients have a back, the small of the back has like a butterfly-shaped defect that goes about like this, about that big on most of them. And it has like fibrous lines that go like this in both directions that simulate the vertebral bones and the gaps in between. So those, I think, are signs of slow microscopic cerebrospinal fluid leaks, which is why a lot of people get headaches, especially when they wake up in the morning and sit up. So I look at the back, and I'm surprised to note how many patients tell me that I'm the first doctor to look at their back. And then, of course, in these patients, we want to order an MRI scan because the arachnoiditis shows up as tethered cords, rippling of the skin, loss of the paraspinal muscles, empty sac syndrome where there's no nerves in the middle of the spinal cord itself, but they're all impacted around the edges. But certainly, if somebody has an MRI that does not show anything really huge, that doesn't mean they don't have arachnoiditis. The sensitivity of that test for this isn't 100%. So it is and always will be a clinical diagnosis. So I only need the history and the physical exam to make a diagnosis. The MRI can confirm the diagnosis, or it can show maybe some early changes that are subtle. And we're going to be working with a private radiology group to further streamline the diagnosis of arachnoiditis on MRI so that we can have, there's like a couple of grading systems already out there, but we want to make sure that it's as thorough as it needs to be. So we'll probably end up redefining that as well.
Okay, we have a quick call. We're going to take a caller from area code 262. Welcome to Conspiracies Against Wellness. What's your name and what's your question?
Hi, this is Dave from Wisconsin. Thanks for all the very precise information, especially about arachnoiditis. I commented that the first thing a doctor is an observer, and it's obviously to see you appreciate that too. I don't want to change the subject from arachnoiditis, especially for all the arachnoiditis patients here, but I have a rather top-to-bottom congenital canal and foraminal stenosis. And I've been cut off from opiates for 2 years, and boy, that was everything to me in regards to mobility. And now I've been diagnosed with an advanced heart failure, I have to assume because of atrophy, and I've refused to turn it on, even though it hurts sitting still. I can turn it on by jumping around and moving and doing normal things like showering and stuff. What do you see a lot of congenital canal and foraminal stenosis, and what don't I know about it as far as long-term effects? Thanks.
Got you. No, thank you very much. No, I have not seen what you're describing as like a whole spine congenital defect that makes your foramens close up. I would imagine your cerebral spinal fluid probably doesn't flow as streamlined as most others. This is a concept that I teach a lot. The brain and the spinal cord are connected in the spinal canal, and they're surrounded by the cerebral spinal fluid. And then there's a pia layer that's like this, a pia layer on the outside. The arachnoid layer is kind of like in between. It's a space with little things in it. And then the dura is like my skin. It's a hard, tough tissue, and that's what we would poke through as an anesthesiologist if we were giving a spinal tap, for example. and then the cerebral spinal fluid is on the other side. So the exchange of this fluid happens about 5 times a day, and nobody knows how or why. So one of the drugs that we use to encourage the flow and to dilute out inflammatory markers is to use a drug called Diamox or acetazolamide. The smallest dose is 125 milligrams. Usually we start with a quarter of a tablet, like on Monday, Wednesday, Friday. And some people go up all the way to 500 or 3,000 milligrams a day, just to diurese, to urinate, and to keep that fluid exchanging. So I imagine something like that may help you, but I'm certainly no expert in that particular diagnosis. And although I haven't seen it before, if I saw you in person, I'd be able to ask you more questions and maybe get a better idea. But I think there are still a lot of things that could help you. And certainly with a history of congestive heart failure, our opioids are very good for the heart. They don't depress it any worse. So I would still think there's a lot of hope for you to get some good medication that would make you feel better and make you want to maybe participate and do a little bit more than you can now. Like take a shower. I know that can be a great thing to do.
There's several people asking why are they giving so many spinal injections and blocks?
That's a great question too. That's a wonderful question. Part of the answer to that is because we're all struggling for something to do that can help. Certainly some patients can benefit from it. Certainly if you have 1 that didn't work, 2 that didn't work, 3 that didn't work, you can stop and never have another one again. Because they didn't work. Studies show that epidural steroids, epidural local anesthetic, injected can damage, and it can also accidentally get injected into the cerebral spinal fluid, and it can cause arachnoiditis too. So it's a system, I think, where this is an example of Toyotization of medicine, where people don't want to prescribe opioids, and so they're forcing patients to do other things first. And a lot of patients have told me that they feel forced into epidural steroid injections. I actually wrote an article on Pain News Network that is like, I think, 10 things you need to know about epidural steroid injections. And if you visit the FDA website on epidural steroids, pretty much they say you could die. And a bunch of patients did die because one of the vials was contaminated with fungus. So yeah, we're getting into a space that's pretty close to your spinal cord, and you bet there are a lot of bad things that can happen. So I think the answer to the question is that doctors are looking for solutions, and so they're trying everything besides opioids. But I don't think that means that every single patient should be required to have one before they get proper opioids, for example. And I want to also just say one other thing. In our clinic, that we have like the top 3 drugs that have worked really well in combination. I call it a combination therapy, and none of them is an opioid. So there are things that act in the spinal cord to decrease the spasticity and the jerkiness of muscles and dystonia and hyperreflexia. People are jerking in the middle of the night. Their watches are breaking on them because they have so much electric current going up and down their spine. I literally have a handful of patients that can't wear a watch because they break them. So we work with several drugs to try to stabilize the spinal cord. And once the spinal cord is stabilized with something that's not an opioid, then guess what? You don't need that much and you feel better and you're happy because you're not jerking anymore. And actually your spouse is happy because you're not waking them up all night jerking in the bed, and you're not, up and out walking and running around. So we definitely that can help.
Yeah. You wrote The Rebel Patient. Can you talk a little bit about that, and why did you write it?
Thank you. Sure. That book was inspired by Stanford. I was reading on one of their websites, and they had a comment or two in a small paragraph somewhere about the rebel patient who asks questions, who understands their disease more than many doctors do because they have it and they've been researching it for years. And I realized that in my struggle to get well, I had to bottom out and almost start dying. And I took myself off of every medication that all my doctors had me on. And I went on a strict anti-inflammatory diet. And I think that helped save my life. So the Rebel Patient came as a opportunity to walk patients through the physical exam, the thinking of doctors, what we look for. I also really want to encourage patients, especially those with chronic pain, to learn how to answer questions to their doctor. If I ask you a yes or no question, I just need a yes or no. I don't need a story. Why? There's only a certain amount of time that we have. I'd love to chit chat, but listen, at the end of the day, I've got to write some prescriptions, and I don't know what to write for you if I don't know what you have. So if patients could imagine that I'm asking you a question up here, if your answer is yes, I'm going to go this way. If your answer is no, I'm going to go this way. If your answer is maybe or I don't know, I'm like all three. I'm like everywhere. So then I ask you the second question, and then that's going to split off to yes or no. And then each one of those is going to split off to yes or no. So you need to let me think as a patient so that I can do it my way and I can grasp and ask you really good questions. And a lot of times I have patients say, gosh, how did you know to ask me that question? Because I put myself in your shoes. I feel what you feel. I'm an empath too. And so I don't know how I do it exactly, but I get feelings and instincts, and then I may go down a completely different road with one patient versus another. So the best patients, that's what I want to teach you. That's what that book is there for. Not only to encourage you to fight for your diagnosis, because then you can put it in a box, you can get the right meds, you can get on with your life, but also to teach you how to help yourself be a professional patient. You have to be a really good patient to get the best quality medical care in our country, and that's just the way it is.
Where can people find the Rebel Patient?
It's available on Amazon.com. Also, the ebook is on at saysagainspirational.com. It's say like say a story. Saga is like a story, and inspirational. It's an inspirational publishing company, so they can go there and order it. And also, if people want to, they can email me and I'll give them a free copy. So there you go.
Okay, great. Someone asked on YouTube, not to be intrusive, do you follow your own protocols or require a lot of medications to live your life as is? You look lovely, vibrant. I'm a retired AF nurse being worked up for arachniditis.
Nice. Well, like I said in the beginning, I went on a special diet myself. The doctors I felt were kind of killing me. I was a walking side effect profile. I didn't even have saliva in my mouth. My teeth were going rotten. And I just gave up on medicine. I gave up on all of it. So I pretty much went away for a year, just tucked away from everybody. So yes, I definitely practice the low glycemic diet. I bake a lot. I cook a lot. I put pictures on the Chronic Life diet on Twitter. And that's the name of my next book, is the Chronic Life Diet. So yes, I have recipes for you online. I have pictures of books. I teach people how to cook. So that's one thing. Number two, medications. I'm doing sex hormones and I take nothing for pain. I'm not on anything except for sex hormones. I do, vitamins. I do some supplements. I do melatonin occasionally, but I pretty much sleep okay. And I'm a lot better off than I was 2 years ago. I'm a lot better off than I was 15 years ago too. So thank you for the compliment. I'm aging too, like everybody else, and I'm just happy to take what worked for me and apply that to you.
Now the hormones, does that help with, I don't mean to be vain, but how you look as well? And in that way, does it help with your skin elasticity?
Absolutely, it absolutely can, especially estradiol or estrogen. Yes, for sure. The other thing about sex hormones, besides the good beneficial effects that it has on your physical body, one of, I think, the most important things that it does for women and men is it gives you your sex drive back, and it makes sex for women less painful, because estrogens can lubricate the vagina and give a really good mucus covering. And also they can make the breast feel a little bit full. So a lot of women feel much more feminine and they just feel better about themselves. And the testosterone gives women, if you can imagine this, okay, we know testosterone builds muscles. Well, it does that. It does that for the biceps. It does that for the hamstrings. It does that for, all the big muscles in the body. But it actually does that for the muscles in and around the vagina and the penis as well. So a lot of women get more intense orgasms, and some women have had their first orgasms on testosterone and estradiol, hormone replacement therapy, because they didn't have a sex drive. I think I have about 5 patients, women and 1 man, 4 women and 1 man, who told me that I saved their marriage. They forgot about sex. It wasn't important to them. And it took the hormone replacement therapy to give them that sex drive back again. And they were shocked that their spouse put up with them being like that for so long, in a way. But they were really grateful that they felt like their marriage was back together, on track, 100%. And there's nothing that can buy that. That's a really good quality of life factor that I think every patient can shoot for.
Are there any side effects to these hormone replacements, or are they creams? What are they? Are they injections?
I like to do injections of estradiol and testosterone. Progesterone is a pill. So for men, they usually need more testosterone than women, and they seem to do well on the injectables. The pellets, that you can get pellets implanted in your buttocks, they last for about 6 months, but they tend to overshoot in the beginning and be too high on the testosterone, which can be bad if you're aggressive. And then towards the end, people get depressed because it wears off a little bit, and then the pellets are still in you, and so it's a little bit of a problem. So what I like to do is start with once a week injections, and then after a few months, most people can tell that they feel good for about 3 days, and then by the 5th and 6th day, they're wondering when they can get the next injection because it's worn off. So testosterone is really known for going up and overshooting right after an injection and staying up for about a couple of days and then going down. So by the 6th and 7th day, it's like almost back down to nothing again. So not everybody can feel that. They can't tell their mood change, but some really can. So what I do in that case is I switch from once a week to twice a week. So, and give a little bit more than half the dose that they were on. That way the level goes up, not so high, but it goes up kind of to a medium level, and then it never goes down. It stays up, and then their mood is more constant. So yeah, there's side effects to everything. You can get acne, you can get a male pattern baldness. There are a lot of side effects that are possible. Men can convert testosterone into estradiol, the female hormone, and then develop female little breast buds. So if that happens, we can reverse that with another drug. So we watch, I'll check blood every 3 to 4 months when somebody's on sex hormone therapy to make sure that they're metabolizing it correctly and that they don't need a little bit more or a little bit less of what they do have. So it is something that definitely needs to be monitored regularly. I see every patient at least once a month, no exceptions.
People are asking about oxytocin. Is oxytocin part of the hormones that you use?
Oxytocin is a part of it's part of a regimen that I use when I put patients on ketamine. We use ketamine for pain control. I also believe that it grows nerves. It makes nerve bundles thicker and increases the number of synapses, so they're talking to each other more. It makes the brain denser. There are a lot of good things about ketamine. And so one thing about ketamine, though, is you can get hallucinations and you can feel like your mood a little bit uncomfortable, like it's too strong. So I use oxytocin together with ketamine in order to make it more gentle and to smooth it out. Also, oxytocin is used for mood, for depression. It's a hormone that's released by the brain, by the pituitary gland during childbirth and labor, so that the uterus contracts. It's also secreted during breastfeeding so that it can let down milk for a newborn baby. And as you can imagine, having a baby and breastfeeding are times in a woman's life where she doesn't want to be alone and by herself. So there's some talk that oxytocin also can help agoraphobia. and get patients out of their house and around other people, which is really good for most people as well. So it's for mood stabilization even by itself.
Who else, or what type of doctor does these injections? And do you take people from out of state?
The injections you're talking about, which ones? The hormone?
Yes.
Oxytocin. You can go to an age management doctor. Not every doctor knows how to do hormone replacement therapy. Is something that we don't really spend a whole lot of time on in medical school. And then after that, we don't put a lot of patients on it ourselves as general practitioners. So I think it's best to go to somebody who has some expertise in that area. And then the company that I'm a fellow with, Cenogenics, in their headquarters are in Las Vegas, and they give us really good instruction as physicians on the latest things going on, not only with the hormones, but also supplements, diet, and exercise too. And regarding out-of-state patients, we have to be careful about that. But normally the patients that come to us from out of state have a retinoiditis also, or they have a pain syndrome that causes central pain. So we start with somebody who's been, and every patient that comes in needs to bring with them or have sent 1 year's worth of physician notes from their primary care doctor or whoever they're seeing, so that we can get a better idea of what they've been through. But yes, I take out of state patients. About 50% of my clinic is from out of state. We're a national referral center.
So where do you see your, where do you see your whole thing going? What are you doing next? Where do you see yourself in 5 years? Yeah.
Yeah, well, I want to write at least 2 more books. They're both in my head, and there actually quite a bit of them are on pieces of paper too. And then I want to give talks. We were going to actually schedule a cruise in the fall and have a pain cruise. But right now, the ship can't give us a conference room. So it looks like we might either try another ship or just go to Disneyland and do a hotel over there. But I want to spend 5 days lecturing all day, every day, starting with diet and insomnia, and videotape the whole thing. So we'll have teaching, talks available. And then at the end of the week, we're actually going to be giving out what I dubbed the Hippocratic Oath Award. It's going to go to Dr. Mark Ibsen in Montana for his work in keeping the Hippocratic Oath for his patients. So I want to do more for chronic pain patients. I want to recognize doctors that have been really good doctors despite the climate in our country. And I also want to say that I'm really happy that the FDA and the CDC have made some major concessions, that their guidelines were never really intended for chronic pain patients. And I feel really badly for the state of our country and what people have been through. And it's my biggest hope that doctors can really learn and be free to be doctors again without the government being in our exam rooms. That's really what I want.
How long do you think this is going to take to trickle down? Because I know they're starting to pay attention and realize that they overshot this whole thing. So what do you see that's going to happen? I know you don't have a crystal ball, but
I think a lot of damage has already been done. Not to be pessimistic, I'm a very optimistic person, but I think there are already a lot of doctors who elected not to renew their DEA license. They just don't want to deal with it at all whatsoever. Period. End of story. So that's a big loss. There are also a lot of doctors, I think, that feel very badly about what they put their patients through by force weaning or by stopping writing prescriptions and having suicides and really bad things happen around them. Physicians have the highest suicide rate than any other profession in the world, and it's always been that way. So I think, and I wrote this in the Rebel Patient book, I think there's going to be a lot more physician suicides because most of us went into this for good reasons. And what happened was against the grain for most of us. And physicians being forced into not prescribing when they have patients in front of them, they're being forced not to have empathy. That's a big thing. So I hope that the medical students and the residents and the fellows get to be around doctors who aren't afraid to be doctors. And as far as the future with opioids and chronic pain, we are never going to see super high dose opioids being given to outpatients to take home. unless they're on hospice care, unless they're actively dying, and then the local doctor will take care of that. Otherwise, we have patients moving to California because some states are just not going to change. Oregon, Florida, Ohio, Montana, there are some very, very difficult states to live in if you're a patient with chronic pain. So I encourage patients to go ahead and move if they can, because that's their life is going to be centered around healthcare.
Yeah. If somebody would like to contact you or check out your website, can you let them know on air what those are?
Sure. Our main office number is the 800 number. It's 800-992-9280. You can also email us. The practice, we just got approval from the California Medical Board. The practice is now Aranda MD Enterprises. So you can email us also at info@arandamdenterprises.com. And then 800 number again is 992-9280.
Okay, great. Well, we're already an hour in and we're going to wrap up here. Is there anything else you'd like to share with the audience before we get going?
Well, I just want to encourage patients listening to, find and investigate and go ahead and take a plunge and do the whole 30 for 30 days. Go to their website, research it, look at how they want you to prepare for it, and go ahead and set the day you're going to start it, and then do it for 30 days. And most patients will lose a little weight and they'll feel a lot better. And then I think that makes you sleep better, it makes you feel better, and it just spurs you on to doing better things. So I just want to encourage people to make good decisions, do what they can with the power that they have in their own homes, and try to make good decisions so that they can have less pain. And go ahead and take some melatonin, magnesium to sleep at night. And once you get your day and night cycles established, you'll already have a lot of hope. You'll feel a lot better.
Well, Dr. Margaret Aranda, thank you so much for coming on. You were amazing and had such great information. I will make sure to share with everybody your information as well when this is finished. And I would like to also remind everybody this Sunday, 6 p.m. Eastern Standard Time, DPP Rally Talk Show with Claudia will be on, and she is having Dr. Feldman. And that is it this evening. I hope you have a great weekend, and we will see you Sunday.
You've been listening to Conspiracies Against Wellness with your host, Janelle Elgoway. The opinions expressed on this program are those of the hosts and callers, and not necessarily those of EXG LLC, its employees, or sponsors. Copyright 2018 by EXG LLC. All rights reserved.